Okay, so hi, good evening, everybody that is joining. My name is Tammy Baillie-Stanton. I'm a specialist emergency physician, and I work at Rahima Musa Mother and Child Hospital. I was asked to give a talk last week at one of our local conferences at the Hatzola conference with the title Tiny Patients, Big Challenges, Innovations in Pediatric Emergency Care. So there have been some pretty cool innovations in medicine, but also in pediatric emergency care. One of the most recent innovations that's being looked at pretty much all over the world in medicine is the use of AI, so artificial intelligence. So AI has been used in some of our first world countries and combined in pediatric emergency care, especially in the pre-hospital environment. And they did a study recently in Sweden, and it was published in the Scandinavian Journal of Trauma, about how an AI algorithm could be used to predict patients, so pediatric patients, that required critical care in the pre-hospital environment. So that's very helpful in determining where a patient needs to go to. So if you're choosing a district facility versus a tertiary facility, it might be helpful to use AI, even in the EMS environment, in the pre-hospital environment, to help decide where a patient need go. So the use of AI is being used for research. People are using it for studying. People are using it also for writing, particularly writing up articles, just because the language facility is very good. But it is also being used clinically to help us predetermine which patients are more likely to decompensate than others. And they found that this particular algorithm that was used by the AI was better at predicting patients that might need interventions, regardless of their vital signs. Other things that are being used in pediatric emergency care are drones. So drones have been described internationally to take AED devices to bystanders so that they can provide bystander CPR with AED. In Africa, we do have the use of medical drones that is expanding our care and expanding our reach. So in Africa, in a lot of the more rural environments, and particularly they've been looking at Uganda and other countries north of ours, looking at the delivery of medications, AED devices by drone. Blood and blood products have been used successfully and delivered from a blood bank to a facility or a smaller facility where there isn't blood and blood products. This makes sense in an African environment when very often the terrain is quite harsh, the roads might be bumpy and fairly inaccessible, whereas if you're able to deliver a unit of blood or other products via a drone, it can definitely cut down on transport time. South African blood services are also looking at the use of drones in South Africa for the delivery of blood products to patients where the units are required. Internationally, specifically in Africa, the drones have been used for the delivery of vaccines. We all understand that it also might be helpful to deliver rapid tests, so rapid HIV testing during COVID testing to the patient's bedside, but also if there are healthcare providers that are needing to get specimens to the laboratory quickly, that can also be done by the use of drones. It goes without saying that drones are very useful in search and rescue and in disasters, because we can then scope out the terrain and have a good look to see what is happening, where are the patients most likely gathered, and in disasters, where do we need to send extra resources, particularly for pediatrics? How do we scope out the area? Well, the use of drones can be helpful. NERS is an advanced tool that is being used pediatrics. And it is actually one of the most research fields for nerves in pediatrics is actually in the neonatal group. So it stands for near infrared spectroscopy, which is a non-invasive technology that continuously monitors regional tissue oxygenation. Now, this is not a new technology. It is already being used in pediatrics. So they are, for example, this little kitty has got a nose device on the head and also has another one most likely placed on the abdomen. It's usually over the renal area, the renal angle. And they have a look to see how is the perfusion in the kidney versus how is the perfusion in the head. And it is being used in children with hypoxic ischemic encephalopathy. But even in the pre-hospital environment, they're looking at using these non-invasive devices. So it's very similar to oxygen saturations, but you'll look at two areas of the body to compare the perfusion in the one area versus the perfusion in another. So this is an advanced technology that is being used in anesthesia. It is being used in ICU, pediatric ICU, neonatal ICUs, particularly in private, but is even being used internationally now, not just in the research phase, but also to see how viable it is to have one of these devices in the pre-hospital transport of sick children. Virtual reality is something that is not new to us. VR glasses are used widely for kids who are gaming, even adults who love gaming. But there's a lot of research that shows virtual reality is a really great distraction technique, especially for pain and pain management. And so the application for pediatrics is in a really good immersive distraction technique that helps to engage the child, occupy their mind, and keep their mind off of the frightening things that might be happening in an emergency department or in a pre-hospital environment. So there's a lot of research out there which is actually recommending the use of VR. I've looked and I've seen in a lot of the stores that we've got really expensive gaming headsets. I know at the Four Ways Mall at the moment, Four Ways Mall, yeah, they've got a VR experience that kids and parents can go through, not just including the VR headsets, but there's also an experience where they've got mobile moving chairs. So you are looking at sort of 3D, but immersive videos, immersive scenery, maybe short movies, that is bringing the experience and making it very real. I found these really cheap VR headsets, they're cardboard headsets that are not that expensive. They're about 300 Rand per box, and you get 2 virtual headsets. The problem with this particular headset, it doesn't have a headband. Obviously, they're cardboard, so it's more like a 3D experience, more like those old-fashioned viewfinders that there were when I was a little kiddie. And what you do is you put your cell phone, these kind of headsets, you put your cell phone into the VR reader. And there's lots of free apps specifically designed for pediatrics, especially in the medical field. So you'll have videos of birds, videos of maybe a dinosaur if the little boy is into dinos, maybe cartoons, and various apps that are free. So if you have got a smartphone and you have access to a VR headset, it's a really cool immersive technology that helps with analgesia in the emergency department. Telemedicine is also not something new to us, but it is being used quite widely during COVID, where doctors, GPs were consulting from home and using their mobile devices, their telephones or their iPads to do consultations so that the patient didn't have to go into the rooms. Telemedicine was used quite widely during COVID, where we had to speak to families remotely because they weren't allowed to travel into ICUs or into the hospital due to COVID restrictions. And telemedicine is something that has been around for a really long time, even since I was an intern. Outreach is often done, so you can conference call a specialist at another facility, potentially show them images on your phone or real-time images of a sonar that you're doing if you have a telemedicine sonar integrated device and a web platform. This is stuff that can be done in a really fancy environment. So if you're in a small emergency department like ours, and we had access to telemedicine with the ped surgeon on the other side, they could see the kid, they could see the vital signs. We wouldn't necessarily have to be doing all of the stuff via WhatsApp and Vula. And there is a lot of research at looking at the use of, or the potential use of telemedicine, even in the pre-hospital environment, more widely studied, obviously, in the in-hospital environment. There are some risks and there are some benefits. So the nice thing about telemedicine is that we can often get real-time advice. So that's rather than waiting till after we've settled the patient and then having to get information across or advice given retrospectively. It also helps improve the situational awareness of the receiving facility. So that's for our EMS teams, but also it helps with situational awareness. For example, if you're phoning the consultant for advice or the pediatric surgeon on the other side, doing telemedicine just gives them a better idea of what's going on on our side to help them understand the patient better. Telemedicine is often used for training, like what we're doing now. And we all have become quite comfortable with sort of online platforms. Debriefing is also used, so at Netcare 911, and even International SOS, they do their M&Ms online. During a period of COVID, we also did our M&Ms online, but we've tried to go back to in-person teaching rather for that. Clinical review meetings can also be held online. So these are all benefits to having access to telemedicine. Some of the downsides of telemedicine, so in our environment where we work at Rahima Musa Mother and Child Hospital or at Helen Joseph, we still do a certain amount of telemedicine. We'll send a photograph of the x-ray, or we'll send a photograph with outpatient features of the dog bite, for example, to the clinician that we're referring the patient to. So if we're referring the patient to plastics or ped surgery. So we do a fair amount of low-tech telemedicine, and we do a fair amount of it with using WhatsApp, our Vula app. So that's the South African-based app where we do all our pediatric surgery referrals. But there's also something that you can consider if you're really struggling with a patient, and that is to conference call your consultant by doing a face call, so FaceTime, doing a video call so that they can see what is going on better. Obviously, the downsides for us is in South Africa, cell phone reception is a problem. We don't have these devices in our hospitals, so we have to use our own cell phone, and we have to use our own data, and the cost can become quite a problem. When there is load shedding, we have issues with reception and signal, which can be an issue. And having to do this whole telemedicine referral, so via WhatsApp, via Vula, maybe even FaceTiming, it can slow things down significantly rather than just being able to do a proper face-to-face or telephonic call, which might be a little bit quicker. I read a paper recently on technological advances in South Africa, and specifically on medical drones in the healthcare setting in Africa. And I really was intrigued by this. It's one of the conclusions that the authors had. African governments should not be too carried away by technology adoption or catch up, but pay equal attention to other areas that need improvements in the health sector. For instance, equipping hospitals and other health facilities with the necessary resources, so beds, ambulances, adequately trained healthcare workers, medical equipment, etc., and better remuneration package for healthcare workers. So I've only spoken a little bit about some of the cool technological advances that there are in pediatric emergency medicine and pediatric emergency care. But I always have to bring it back to where am I working? Where are we working? What are the challenges that we're faced with? Just to make it real, it's all very well for people to look at telemedicine when we haven't necessarily instituted computers and a functional internet in hospitals. So there are wonderful advances that are being seen and actually are being used in private healthcare in South Africa, throughout Africa, but is not necessarily accessible to the state sector. So South Africa really is a country of distinct opposites. We have extreme wealth and the most amazing resources, especially in the private healthcare sector. First world medicine, people come here to train and do fellowships here just because of the wealth of knowledge and medical skills that we have to provide. But we also have significant poverty, and the state sector really does see the bulk of patients, and we are serving a very economically challenged group of patients, and we also are a particularly economically challenged sector in state as well, as we do not have the wealth of resources that first world countries do, or first world medicine, for example, in our private facilities do. So just a little bit about pediatric emergency medicine. It is a super speciality that was documented in 2018. It was signed off by the Minister of Health at that stage. It is a subspeciality that is available to emergency medicine and to pediatrics. So you can specialize in pediatric emergency medicine in South Africa. The only problem is that we don't yet have a super specialty program. I'm guessing that Cape Town will be way ahead of us at WITS, because they usually are, but we're not there yet. So we don't yet have a program where we can specialize in South Africa. However, there are various routes that you can grow your pediatric emergency medicine knowledge and love. You can join up with Paediatric Emergency Care South Africa, so PECSA. It's a special interest group from EMSA, the Emergency Medicine Society of South Africa. I belong to this special interest group. And I sit on the committee to further the interests of pediatric emergency medicine in South Africa. Just a reminder where I work, and that's at Rahima Musa. But just the video that I did was of the last week in our ED, where we were facing significant challenges while the hospital is being renovated. We're delighted because our emergency department is being scraped and replastered and repainted, but it is very squashed, dust flying around, and very noisy for our team. And the video just elicits and shows the challenges that we are faced with in our tiny little ED. I don't know why my video is not showing. Okay, sorry about that, guys. Don't know why. It showed really nicely previously, so I'm not sure why it's not showing now. Sorry about that. Okay, moving on. Some advances in pediatric emergency medicine is the use of point-of-care ultrasound, used widely in emergency medicine. You can't be an emergency medicine practitioner without loving the ultrasound. And the same goes for a pediatric emergency medicine practitioner. You have to love ultrasound. It's one of the coolest applications. I did a talk recently on what of all the different kinds of ultrasounds that we can do: cardiac, skin, skeletal, lung, neurological, GIT, airway. There's all sorts of different modalities that we can sonar. We can sonar the kidneys, we can sonar the bladder, all sorts of things where point-of-care ultrasound is particularly helpful in the bedside management of patients. I love all things ultrasound, and this is one of the things that a pediatric emergency medicine in South Africa is growing in. We're growing in an interest in point-of-care ultrasound. And all of our emergency departments, at least the academic emergency departments, have ultrasound. So this is an advanced technology that is readily available for us. And it's great because it can take a long time to get an ultrasound. Some settings we don't have access to a CT scan, for example, at my facility. So having an ultrasound really does help us cinch the diagnosis and help us with our diagnostics in the ED. And our setting where we don't have a laboratory at nighttime, it's really helpful to be able to do an ultrasound because it gives us a little bit more information. And it also helps us guide, do we actually need to send the patient to another facility for a CT scan, or are we okay with what we've got in front of us? Things that we can control is our environment. So how can we make our environment more child-friendly, more kiddie-ready? So this is a photograph of the back of one of the private healthcare ambulances. So it's the Netcare 911, has got a pediatric pediatric ambulance, which is super cute, which has been fully kitted. It has all the usual functions of an ambulance. However, there's a special seat closer with mom to sit closer, and it's been decorated really well. So looking at environment, this is something that doesn't cost us necessarily a lot of money, things that we can do to help with distraction and to help to bring down the anxiety in emergency care. Analgesia, this is a picture of a mucosal atomization device, which is really great, can be used for any number of agents. Fentanyl is one of the more readily available agents for rapid analgesia in the ED. And considering we no longer have access to Valeron, it's really important for us to be able to have a mucosal atomization device. This is the one that we would potentially use in our setting in my department, because we don't have the commercial atomizers. And if you guys want to see how to make this and to have a look at the video that is on YouTube, look at the Brown EM blog. If you've got access to Gelcos, you can make your own atomizer, and it's really cheap. All of us have access to Gelcos when we might not necessarily have access to a mucosal atomization device. So please do use this and administer your fentanyl to a patient. So it's 2 micrograms per kg, 1 microgram per nostril. 1 microgram per kg per nostril. How else can we improve emergency care? So we have drafted clinical protocols for our emergency department. That is a growing document. It's a living document. But things that really have been proven to make a difference worldwide, and we've learned it from the aviation industry, is the use of checklists. So the one checklist that we've got in our emergency department that is really cool is for procedural sedation and analgesia. You'll see it takes you through the assessment, planning your equipment, getting consent, your medications, remembering that you do need to look at the dosing, what kind of equipment and monitoring do you need? Do we need to look at fasting guidelines and then safe guidelines for discharge? There are numerous checklists. So for intubation, for RSI, for procedures that very much are high acuity or high risk procedures, maybe that we don't do that often. So for an airway, for the establishment of a surgical airway, checklists have been added into theatre many years ago, surgical safety checklists for WHO, and they've made a huge difference to clinical practice. So the evidence around checklists is really vast, and they're widely accepted as they do make a difference clinically, and the evidence backs this up. So I'd like to recommend that you guys use checklists. Even if we can't print one out for every patient, open up the page and look at the checklist, or open up the checklist on your phone, because this does make a difference in pediatric emergency care. All right, so things that definitely help with pain. It's not just pharmacological management, and we have to do a lot of procedural sedation and analgesia in my department, and we use ketamine all the time for our many children with burns. But please don't forget the non-pharmacological methods. So distraction, talking to the kitty, getting the mum to talk to the kitty, position the kitty on mom's lap if possible. Other distraction techniques are letting the kitty draw if they're able to, looking at cartoons, looking at something on mom's cell phone, looking at something on your cell phone, so playing them music, showing them a video. Cold ethyl chloride is particularly helpful. I'm going to ask whoever is online, please can you mute yourself, just because I'm finding it a little bit distracting. So somebody's sound is on, sorry, and it's just distracting me. Thanks. I'm sorry, go back one slide. So pharmacological methods for analgesia, but how do we take down the fear and the terror with the kiddies? So using cold, for example, our ethyl chloride spray, cold compressors, maybe using pressure. So for example, the Buzzy device, that is an awesome distractor. Bubbles are a really good distractor and are really cool for kiddies too. Having little mobiles up in your procedure area for the kids to look at, putting pictures or posters on the ceiling while kids are lying down so they can look at stuff, all sorts of things that we can do to help manage pain. And there's a lot of evidence that these techniques are very helpful too. Other things that don't cost us a lot of money, have a free app on your phone or a minimal payment app to help you with dosing. So my favorite one is Paediatric, and use whatever memory aids that you can have. So instead of the Braslo system, we use the Pauper tape system in South Africa. The benefit of it is that it is designed for children in low income settings. It is validated in South Africa. It's validated internationally, and it is better used in patients with socioeconomic environments similar to our own, as our kids do not tend to be overweight. They very well might have significant nutritional disorders. So using the Pauper tape system is great. It helps us estimate the weight based on length, but also helps us with dosing. And the nice thing about the South African card, it actually explains how to draw up the medication. It's not just the milligrams of the medication. It's how do we prepare it for safe administration. So it helps our nursing staff too. Okay, training. I was super excited when we got our mannequin for doing high-tech, high-fidelity simulations. But please don't forget that you can do really cool tabletop simulations as well. And it doesn't cost a lot of money, just the cost of printing, to be able to do a simulation in your environment. And it just makes it a much more interactive way of discussing cases and of discussing emergency management. So training is a really important thing to be done in improving pediatric emergency care. And there's also a wealth of information and a wealth of evidence behind simulation training. It improves clinicians' skill retention, improves their confidence, improves communication, and actually also improves time to critical interventions as well. I strongly believe in the use of education to improve clinical care, and at least this video is showing. This is a video when we received our mannequin, and we were doing a scenario on a bradycardia with a cholinergic toxidrome, so a kid who'd had an accidental organophosphate overdose. And we see one of our healthcare providers there intubating the mannequin. So I'm a big fan of simulation, whether it's tabletop simulation or in person. This is a photo of our registrar group. We were doing a critical care conference, and the scenario that I did with my team, with my registrars, was a pediatric emergency care critical care retrieval. So here we are with our simulations.